Great. So good evening, everyone, and a very warm welcome to this session. And before I invite Dr. Rosalind Rachel, who is the chair of the Education Committee of ANI, I just wanted to brief that Association of Nurse Executives India. We have been around from 2017, and we have been doing a lot of educational activities. And this year, Education Committee of Association of Nurse Executives India, or I call ANI, we have decided to unsilo nursing and also invite speakers from other disciplines and also invite guests also from other discipline. And we are very happy that we are happy to see doctors also in the audience. That is great. And this is the first time that we have actually got such a senior and an expert on the topic. I will introduce Dr. Mani in a while. Before that, let me ask Dr. Mani to put on the video. I will request Captain Ajita Nair also to come on the video. Dr. Mani, can you put on the video, please? When Thank you, sir. May I now request Dr. Rosalind Rachel, who is the chair of the Education Committee of our association, to give a short welcome address.
Thank you, ma'am. Good evening, ladies and gentlemen. On behalf of the Education Committee of the Association of Nurse Executives India, it's my pleasure and privilege to invite the distinguished guests who have come in for the webinar this evening. We hold such important webinars on behalf of the Education Committee. And today, I hope this would be a very insightful webinar on the status of withholding, the DNR in India. So our distinguished guest, Dr. Mani, is here with us, who will be deliberating on this insightful thought over the next 1 hour. I hope we will have more questions at the end of the session, and it will be more of a discussion because we have a lot of questions related to that. And I encourage each one of you to actively engage and ask questions. I also invite our president, Dr. Ajita Nair, and all the members of the Association of Nurse Executives India to join with us, and hope this 1 hour deliberation will be of great help to each and every one of you. Thank you for joining us today. And I request Ms. Tangam Gomez, who was the founder and the former president of the Association of Nurse Executives India, to introduce Dr. Mani, and we will go to the session. Thank you, ma'am.
Thank you, Dr. Rosalind. Before I introduce Dr. Mani, I have known Dr. Mani for many, many years. Let me invite our current National President of Association, Captain Ajita Nair, to say a few words on behalf of the association.
Thank you, Tangam ma'am. Good evening, Dr. Mani. I have known you also for a long time, though we haven't worked together. I was with Fortis for a considerable time at Gurgaon. Welcome all the delegates who are attending, and sizable attendance is there, and we are expecting many more, and we are, I guess, live. So just an introduction, 2 sentences is what I wanted to tell. Our association has realized that it's an association of nurses in India, and we have realized that yes, we do a lot of hard work, we do interact with nurses, but however, we work together with many other people too in the hospital, and all the time we preaching to the nurses alone will not find much results. So of late, we have realized that the more we involve other people and in our discussions and allow them to talk and we hear them out, will result in better patient care, safer patient care. So that is what Tangam just mentioned as unsiloing nursing. So it is not only nursing, every one of us have to unsilo ourselves and leave from our own comfort zones of our own people to interact with the other people, and that is where the patient care reaches its optimal level, is what we believe in. And Warm welcome to you, sir, for delivering such an important topic, which is, I mean, we all of us being in healthcare, we involve ourselves into such ethical dilemmas, especially the nurses who are working in palliative care or intensive care, to do it or not to do it, and a lot of issues with patients, their relatives, and with ourselves too. Many a times it sometimes conflicts with our own value systems. Yes, we don't have a finite answer, so we are looking forward to listen to you as to what is the current status of withdrawal and withholding, as well as do not resuscitate status in our country. Thank you so much, sir, for agreeing to come to us and talk to us. Nurses are very closely involved in all these issues when we face in medical care. I hope listening to you, nurses will be able to take more, role and contribute more into these vital aspects of medical care. Thank you so much, sir, and have a great time to the delegates and participants. Thank you.
Thank you, Captain Ajita. Just give me 2-3 minutes just to introduce Dr. Mani. And I'm sure that many of the people, we already have close to 86 people on time. That's a record. So it kind of shows the interest that people have on this topic and the dilemma that they may be facing. So just give me a moment. I will just share the presentation, and it's an honor for me to be introducing Dr. R.K. Mani. I have known him from 2006 when I came to Fortis Vasant Kunj. And from that time onwards, sir had been talking about end of life care, how to make, patients who are ill to be more respected, comforted, supported. So I was sharing with Ajita the other day that we had open visitation and we went through our own problems of having open visitation. While we understand the sentiments of having such a protocol, but there was challenges also to overcome. So had been great, and sir has been the pioneer around this topic. And so I just put together a few of the things that describes Dr. Mani. And he's a pulmonologist and he's a critical care specialist. So he is former president of the Indian Society of Critical Care, and contributions in non-invasive, invasive mechanical ventilation, extracorporeal lung. And I remember him as the expert in pulmonology. His medical ICU used to be jam-packed all the time, with all the chronic lung disease patients, and everybody wanted Dr. Mani only. And but he has been involved in intersecting the regions of medicine, human rights, and he has published as the lead author for for the Indian Society of Critical Care Medicine on end of life care. So as I told you, he's the pioneer, and you can see that he has done a lot of work around that. He as a chairman of the End of Life Care India Task Force, so he has taken the initiative, which became a legal policy. He had pleaded in the landmark judgment of Common Cause versus the Union of India, and instrumental in establishing the right to execute a living will. And I'm sure the sir will be talking about it, because I don't think that many people are even aware what is this, living will, whether people will honor it, what the family will do. So there is a lot of, questions around it. And I really hope that all of you will engage and put your questions in the chat box as things are happening, but we will take to us at the end of the session. And obviously, sir has more than enough publications, but 2 publications around the DNAR is, presented here. And representing the ISCCM, he was an appellant in the recent Supreme Court judgment simplifying the procedure for withdrawal and withholding. The last one is something that I have not read across, so I am looking forward to learn about it also. What does all this mean for doctors and nurses, and also as people, because we also have family, we also have people who are falling sick. And as Ajita told, many times we are faced with ethical dilemma. I have faced this personally, because anything happens in our family, I am the one from healthcare. So everybody will say, you advise what to do, Should we say they should take treatment, or should we say, should we stop? And they are hanging on to our words. And then tomorrow, then they will say, Didi ne bola tha. They call me Didi. I said, Didi told to stop, so we stopped. So then somebody, my brother will say, who asked you to advise me? So all these things keep happening. So I hope that from now on, at least I can be more confident in saying this is the law and it permits, and we should do that. So thank you so very much, Dr. Mani, for accepting our invitation. And the interest on the topic is very evident with 100 plus people sitting here. And we have taken 11 minutes extra. So I am sure that if you give us little extra time, audience will have no problem. So over to you, sir. You can share the screen and start your deliberations. And thank you so very much.
Thank you very much, Association of Nursing Executives of India, and Thankam Gomez and Rosalind, Rachel, and Captain Ajita Nair for this opportunity to talk to you all on a subject which is very close to my heart. So I'll share now, screen share. There we are. So the topic that I'm asked to speak is on the status of withdrawal, withholding in DNAR India. Of course, this is a vexed question. What is the status now in the last 20 years of my journey in the subject? And this status has moved forward yet remained static. Both are true. So I'll take you through some of my thoughts on the subject and then bring you up to scratch about what is the status. See, might have heard of Thich Nhat Hanh, the Zen master. So he represented the cycle of life and death like this through his own hand, hieroglyphics. The cloud never dies, which means that there is a cycle. There's a cloud, there's water, there's vapor, back to cloud. So there is this balance. Obviously, in modern times, we are not looking at the whole picture. It's got a bit unbalanced. Now we prefer birth to death. And we have become a death-defying, death-denying, death-fearing society. And partly it's because of advances in medicine, in fact. Quite a substantial amount is advances and expectations from medicine, which has made us believe that we can forever fight death. Though it's very unrealistic, because the one irrevocable truth throughout the history of mankind is that death can be forestalled, postponed, but not prevented. And death is not necessarily, in the larger picture, a bad thing. Imagine life without death at all. Imagine a society without death at all. So anyway, around it is so much science, philosophy, ethics, morality, ecosystem, economics, politics, around this one death and dying. So setting the scene for talking about death and how we manage, how we respond to the challenges of death. To take this forward, last year, a very comprehensive document on death and dying was published by Lancet Commission on the value of death. So death is not something to resist or to deny, but it carries value, as all life carries value. What we understand through this document, which is very touches upon so many aspects of life because they all intersect. What we understand as pertaining to medicine is that death, dying, and grieving in the ICU setting needs to be managed wisely, pragmatically. It has to be even more ethically grounded than in more usual ordinary settings, because they all come to a fever pitch, the intersections of ethics, morality, legality, and philosophy, and virtues as a human being. They all come together. And if we have to respond to death properly, we have to respond in several dimensions, including community participation, including competencies and communication, including cultural resetting, and also national policy. So you can see the impact, the importance. We'll focus on the subject of withdrawal and withholding, as the title says. So to define what it is, not to have woolly or fuzzy ideas, let us look at this picture. Withholding means not to start an intervention at all, right? Not to start an intervention like mechanical ventilation or vasopressor support or dialysis or ECMO in modern times, or any other device that sustains life in certain circumstances, obviously, in the context. Withdrawing is once having started an intervention, since it is going nowhere, you interrupt it, you stop it. Now, ethically, withholding and withdrawing are the same by the ethical pundits and also by the legal pundits in the majority of the world, where these practices are well refined. Why? Because the premise for both withholding and withdrawal are the same, that it is pointless to institute, in certain circumstances, aggressive interventions because they will do more harm than good. Firstly, they are pointless, non-beneficial. So that is, we want to benefit with any intervention. Secondly, they may do great harm by depriving the patient of dignity, but depriving the family of access to the patient, and also in the economics. In 1979, the first edition of the Principles of Bioethics was published by Beauchamp and Childress, which largely defines the ethical grounding of modern medical practice. And this is what we follow as well in our country. The ethical questions are addressed by this big book in 4 principles. Principlistic ethics, it's called: autonomy, beneficence, non-maleficence, and social justice or justice. So obviously, you know that autonomy means you respect the personhood of the patient. And so the patient is in control either directly or indirectly through valid surrogates. And beneficence and non-maleficence are the obligations of the caregiver. They are the promise that you're given. I'll work always to the benefit of the patient, and I will work in a way that I don't harm, right? As far as is possible. If there is a conflict between doing benefit and doing some harm, because every intervention has some harm, the benefit should far outweigh, and it should not be an inordinate level of harm for any intervention. And social justice really means fairness, dealing with people equitably and using resources wisely, so that use of it doesn't deny somebody else of the valuable asset. Although these 4 principles are supposed to govern all our decision making, and all are equally important, but some may receive more weightage than the other in an individual case, is supposed to be within this framework in any decision making, and that comes to a head, it comes to the fore in the complex decision making around end-of-life care. But they must also include elements of the other ethical philosophies which have evolved over the last 3 centuries. Deontological means for itself, right? Kant's categorical imperative says something is important in itself, not because of any benefit, but value in itself. For instance, speaking the truth, disclosing the facts of the case is a requirement in itself. Consequential ethics is something that is utilitarian. That is, it produces the outcome you desire. Okay, in quantifying the benefit, then it should clearly show up as a desirable consequence. So this is a more utilitarian philosophy. And virtue ethics, that the individual doctor, individual physician or nurse wants to value the person, wants to treat the person as an equal, and feels compassion. So all these elements have to go into our decision making. So this is the beginning. It is not the after law. It is our essentials, and the law is only enabling this in a very systematic way, enabling ethical decision making. That's what law purports to do. See, there are what's a good death? We have the Indian view, Hindu view, Christian view, Buddhist view, of what a good death is. Everybody's agreed that it should be peaceful, it should be among loved ones, it should be dignified, it should not be ugly, it should be pain-free, and so on. So there are 11 attributes of good deaths which experts have agreed upon, and which has been stated in that document by Lancet. But one prominent feature of a good death, which I want to focus on today, is not a death not being unnecessarily prolonged. Okay? Just stretching somebody out pointlessly is not the idea of good death for anybody across cultures. Because to the patient it causes harm by prolonging death, and it's against the bioethical principles, all the 4 principles, and also virtue ethics. You don't want to prolong the process of suffering. To the family, of course, it causes great dissatisfaction to have the patient die slowly or miserably and alone, right? Just surrounded by these machines and devices and not having proper access. And the patient really needs the family the most, shut out. Previously, people used to die in their homes, in the communities. But now, death is concealed. Death is not seen. It's become medicalized. It's happening in hospitals, in ICU. So that is a big loss to the human experience itself. So families may face post-traumatic stress disorder lasting a lifetime if they go through this painful process, not to speak of the economic distress in our out-of-pocket healthcare system, largely in our midst. This is a huge problem. People can get below poverty line. In fact, 40% of families, by one survey, shows that after an ICU admission, get economic distress. Either their lifestyle changes, or they go below poverty line, or they have to sell off some property or the other. To the caregiver also, it does not spare, cause moral distress. We don't like to. We don't want to enhance suffering. We are caregivers by instinct, and by training, and by what you call goals. So we want to alleviate suffering, minimize, reduce. Particularly the nursing. The whole of nursing has started with this concept of addressing suffering more than disease. And when your compassion is not relatable to what is happening on the ground and you're not able to control it, gives you compassion fatigue and gives you the impulse to leave work, go somewhere else, do something else, not do caregiving anymore. Or even if you continue on the job, you do it listlessly. Okay, you lost the verb, lost the passion, you lost the efficiency. And then violence at work is real in our midst. And it is the people on the spot, okay, the front line doctors and nurses who face daily verbal or physical violence. To the healthcare systems is untold damage in the form of resource misutilization. And that is really self-explanatory. We've all witnessed how we are short of beds, and we saw that during COVID times. The people lined up outside, even outside the ER on trolleys, not finding a bed, in fact, with air hunger, they were waiting. Death doesn't have to be miserable. Death doesn't have to be, the picture that I showed you earlier. It can be this. In one of my recent patients, facing advanced cancer and also intractable heart failure. So what was the treatment here? Treatment was conversation, setting goals, making him comfortable, allowing family. Tankam told us it's inconvenient to have an open visitation policy. It's inconvenient, like many, many good things. But it does a world of a difference to the patient and family. Then it's our pick what we want. We want convenience, or we want this picture. You can even see grandchildren. Many times children are not allowed in hospitals. But we make an exception for end of life care. That's the time when the grandfather needs them the most and the grandchildren needs them the most. The closure, the completion of a story, a person, and passing of the legacy to the young ones is such an important part of life and living and death and dying. Now, I'll give you an example of withdrawal. Most people are very scared of withdrawal. And you withdraw, the patient seems to die soon thereafter. So the proximity of death after a withdrawal procedure, say extubation, frightens us and we think it's illegal. I want to say it's absolutely legal. And of course, I'll show you Supreme Court judgments. But it's never been illegal. That is another story. Now, this was even before the Supreme Court judgment that this patient came to me with advanced ILD, 102 years old, a religious personage from Vrindavan. Now, you see, he had a large following. Many of them were doctors. And they wanted everything done, if they didn't coach, everything done. See, everything done doesn't mean that you subject patient to futile treatments and aggravate the suffering. And as I said, stretch out a dying process, which if natural is redeeming and dignified. In spite of good conversations, they chose to have this person ventilated. But I put a condition, and which we agreed on, that there would be a time-limited trial. In 48 hours, if we are going nowhere, then we will remove the ventilator with the due, of course, control of the symptoms that come during extubation. So that's what happened. And after 48 hours, the followers themselves came and said, "Doctor, please, he's going nowhere. We are apprehensive. Let's take him to the ashram." And there we extubate, which is what we did. We took the patient to the ashram and extubated him with the anticipatory analgesia and sedation. We were all there, me and a few of my team. And we put him in the lotus position, which is what religious personages, the rituals, there are rituals for death of religious personages, and they are also part of dignity in death. So a lotus posture could be done because we could act before rigor mortis, and all the due laws by Shastras were followed, and so there was general satisfaction and aesthetics and spirituality in the death. So this is quite possible, and we also made the death summary in the ashram and did the certification. So even the practical matters were more easily and smoothly settled. Now before the law comes consensus standards of care. Standards of care and end-of-life care has been evolving over the last 30 or more years. In fact, the laws in the US came in the 1970s enabling it, and Patient Self-Determination Act came about in 1991. And the first DNAR order was written in 1974 in this world. And the codified law in the US for DNAR was 1988. So we are a good nearly 50 years behind. However, we will be late, but not never. There are worldwide position statements, professional position statements. After all, law is made looking at the opinions of the professional bodies, okay, and professional requirements. So the Indian position statements are there by the ISCCM. The first one was written in 2005. And there was an iteration in 2012 and 2014. And now we are making new guidelines now, which should appear within 3-4 months. There was joint position statement in 2014 of ISCCM and Indian Association of Palliative Care, IAPC. There's also Indian Association of Pediatric Guidelines, which are very similar in lines and thinking to ISCCM, IAPC guidelines. And there were more recent publications post 2014, the FICCI illicit guideline. So Federation of Chambers of Commerce and Industry, FICCI, along with End-of-Life Care in India Task Force illicit, formed by 3 associations in ISCCM, IAPC, and Indian Academy of Neurology. I'm also chairman of illicit. So we are an advocacy group for improving end-of-life care in India. The Blue Maple is a very comprehensive document, which also gives us the forms and the SOPs of how to go about it. This was published by the Manipal Group of Hospitals, authored by an eminent palliative care specialist, Dr. Naveen Salins. We have also worked with ICMR, Indian Council of Medical Research, and created 2 documents, definitions of terms in end-of-life care. We seem to, sort of put everything in one basket. Euthanasia, withdrawal, withholding, DNAR, okay, everything in one basket. So which is very wrong, obviously. Infection has a different definition, sepsis has different, septic shock has another, isn't it? So there are 25 definitions given in this document, and we also created a document on DNAR in 2020. And then there was a model legal framework made by legal experts in consultation with medical experts by the Vidhi Center for Legal Policy. This was also in 2019, then iteration 2021. So all these documents are there, all these references are there for you to see. Quality of Dying Index was created by the Lien Foundation of the Economic Intelligence Unit in Singapore. First one was in 2010. We were the 40th ranking out of 40 countries. In 2015, we were about 67 of 80 countries. And the most recent was 2021. We are 59th, you can see, out of 81 countries, and below us are generally countries where end-of-life care is not well developed. You can see right at the top is United Kingdom, where palliative care is very highly developed. You can see Taiwan, Australia, You know, these countries are right at the top. Canada, even the US comes at 42 or 46, I think. Yeah. So we have a lot of catching up to do. What are the barriers and difficulties in our list to achieve a quality, good quality of dying that we deserve? Kerala stands out as the leading light in this community-based, volunteers-based care of the dying, end-of-life care in the community. So it has been recognized in this document as a model created by Dr. M.R. Rajagopal of Pallium India. So there is one island of excellence amidst mediocrity, as I can see. So we can learn from within the country and outside the country to take this mission forward. The barriers are mainly hospital policy. They don't see the importance of having an end-of-life care policy. What you're not aware of, you don't act upon. So actually, NABH approached us, me and my team, and we created the COP 20, or was it 22, which is end-of-life care policy and SOPs. And I think there are 4 or 5 points. We must have in place training. We must have in place a policy document and also necessary drugs such as, narcotics, so on and so forth. But unfortunately, NABH sort of fearing the law wrote that it should be in consonance with the law. So that sort of vagueness has impaired the implementation on the ground. So there have been social norms and taboos against even mentioning death. So when that the Lancet Commission for the Value of Death was published, it was launched, and I was asked to speak for 5 minutes. I read through the document a couple of times. It was very stunning, the way they made it. So my comment was that we are afraid to mention death in the ICU, and we must not shy away from it. So there was a cartoon in real time, so posted on Twitter, my saying that we must discuss death, which should not be a taboo. Has been a taboo, but we must break the taboo. We have had great overriding fear of the law, a law which we didn't take the trouble to read properly, the law which we didn't take the trouble to understand and to inform. It is the duty of the professionals to inform the law. It doesn't happen on its own. And there has been great worries about cost of continuing treatment in the ICU, particularly accentuated by the fact that you can't withdraw, and therefore there's only one way you keep on escalating. So that has aggravated the cost burdens to the families. In a recent in-depth interviews of 22 intensivists, Dr. Shivkumar Iyer, who is one of the first intensivists to undergo the palliative care course in Cardiff, MSc, and as an MSc thesis, using a robust qualitative analysis methodology, where when the intensivists were interviewed, they were anonymized, of course. These were the difficulties they mentioned: the hospital policy, the social norm, fear of litigation, and cost. There's very few case laws on end-of-life care. When I started on this journey in 2003, there were just a couple of case laws. There was striking absence of any mention of anything to do with death and dying or end-of-life care in our laws, or any case for that. So the first real case law was the Aruna Schonborn was the Union of India in 2011, the Supreme Court. So which addressed the issue of so-called passive euthanasia for Aruna, who had been in a vegetative state following a brutal rape and strangulation for upward of 30 years. And so in principle, it was agreed that passive euthanasia, that is unfortunate, outdated term they gave to withdrawal and withholding, is legal. It's decriminalized. It is not to be confused with suicide law. It's not to be confused with abetting suicide. So that was well established, but it needs a consent of the immediate caregivers, next of kin. She had no next of kin, only nurses. So nurses of came hospital, they had cared for her for decades, and they said no, they don't want to remove any supports. Now, see, while you might think nurses have done a very, very large-hearted thing, but the focus was on should not have been on the nurses. The focus should have been on the patient, what she would have wanted. She would have wanted another decade of this sort of state. So that sort of discussion never went through. What I'm saying is, there was a paucity of understanding of the needs of the dying, or understanding of the limits of science, and the understanding of the human rights, which we share with the Human Rights Commission also in the world, and fundamental rights enshrined in our own constitution. So we never discussed any of those things. So it was not a judgment that could help us. They wanted everything to be routed through the High Court. It's not possible. Nobody utilized it. There was a case by the by the NGO Common Cause. The Common Cause versus the Union of India in 2005 was filed. I, on behalf of ISCCMIM, pleaded in 2010, which means we had a common purpose. Prior to that, it was declared by the Indian Law Commission that advance will is not for us. If somebody, advance will means what? You have a value system, you have a preference. Towards your end of your life, you don't want certain interventions done, which you can document, because you lose capacity. You're represented by people who may not understand you or represent you properly. So you document your wishes. So from the principle of respect for autonomy flows advance will. And you can, in that document, also appoint somebody to speak on your behalf, a proxy, a legally appointed proxy, one or more of them in the order of hierarchy, can be done and usually done when you execute an advance will. So that was disallowed by the Indian Law Commission, and but then Common Cause and the ISCCM fought for this right of the Indian citizen. In 2018, in a landmark judgment, the constitutionality of withdrawal withholding was doubly established, and by the Article 21, the right to life, which confers us the autonomy to be able to refuse any treatment, and also it confers privacy, the right to privacy, that you should decide, you should be in control of how you should be treated at any time, whether whether you retain capacity or you don't retain capacity. So that was a landmark judgment. However, the breakthrough was made in the constitutionality of these laws, but then it was lost in the procedure prescribed. They prescribed a complicated 3-tier procedure, which involved the bureaucracy as well as the judicial magistrate of the first class, and that was even worse. So we were back to square one. We didn't go very far from the Aruna Schonborg situation. So nobody utilized these laws. Therefore, the ISCCM, represented by me, and the Vidhi Center for Legal Policy appealed for simplification, right? Simplification of this three-tier process to make it pragmatic and user-friendly for the doctors and for the families. And lo and behold, we had another landmark judgment on the 24th of Jan this year. And what it really means. So we had this splashed on the papers as he simplified his order on passive euthanasia. That is, a three-tier process became a two-tier process without bureaucracy and judiciary. So I'll come to that, what the procedure is. Now, as I told you, do not resuscitate should be the norm in an ICU. Already resuscitation is going on in an ICU, and death comes as a terminal event. And if you just pump the chest mindlessly, you may cause more harm than good. For one thing, you can break a few ribs. For another, you can really produce survival in a neurologically heavily compromised state. So these are not desirable. So in most places in the world, 50 or 60% or more of hospital deaths are through a DNAR code. All right. And so the ICMR created a task force. I happen to be a member. And we created this document, ICMR Consistent Guidelines on Do Not Attempt Resuscitation. So we are obliged to discuss CPR and DNAR where you anticipate that such a thing can happen. Not in every case, but where it is, imminence of this happening, or in your understanding, this is likely to happen anytime. We are obliged to discuss the pros and cons of the usefulness or otherwise of CPR. So give the patient and family an opportunity to discuss and to have a combined decision as DNR. Sometimes very clearly futile. There's absolutely nothing going for it, and it's medically futile. Medically, you're not obliged to institute any treatment which you know for sure is futile. So you can take a unilateral decision. But as an act of compassion, you are supposed to discuss and communicate what you're thinking with the family and document properly. How to document? There are forms available as supplement to this document. It's available on public domain. So DNAR really is not a different thing. It is another withholding decision, the simplest withholding decision. If you take a DNAR decision, it doesn't necessarily mean that you've taken withholding withdrawal decisions for other modalities, other interventions. Not at all. They have to be taken separately. You can have a DNAR separately. That is, do not have CPR. It's only confined to CPR. What is the intervention? Most important intervention in the ICU, in where you are engaging in a difficult decision, such as end-of-life decision, is conversation. 95% of the time, this conversation with the family, because patient loses capacity or is unwilling to participate directly. But on occasions, you are able to talk to the patient directly. As one of my juniors just captured this, unknown to me, when I was talking to the patient. So this is possible, and you can have useful decision-making, useful understanding, or connect, doctor-patient connect when you do this. By and large, you do it. This is a picture taken in Fortis Vasant Kunj, years ago when we started on this journey. You can see that doctors engage with families and have a good conversation, sitting across the table, not by the bedside, not on the corridor, or open up the conversation. There may be repeated conversation required before you get to a combined, so-called shared decision. So that is also a separate topic. What is the clinical algorithm to arrive at the decision process? That is for some other time, because now we're talking about the legality. You can see in this simplification judgment, first simplification was how you execute the advance will. Okay. The previous one made it necessary for you to have it attested by the judicial magistrate of the first class, JMFC, which is a tall order. An elderly person facing death, how can you go through the judicial process? Is very difficult. Therefore, we have simplified it. That seemed unnecessary. No other country requires this. So we have agreed upon with the government on having it notarized, either a notarization or signature attestation by a gazetted officer, like any other many certificates that we have. So this looks more reachable, and this was agreed upon by the Supreme Court. So there are many other things, requirements that were deleted, which made it complicated. Now the copy of the advance directive should be given to the family and to persons named as proxies. And it can also be uploaded in the EMR of the hospital. It can be given to your personal physician. And it can also be kept in the certain government authorities, right? Custodians. It can be with the magistrate, it can be with the panchayat chief, right? And municipality. So the government is yet to create custodians of these documents. So that is also being requested by the court that this should be done, directed by the court. So you can see what is the legal algorithm for a valid end-of-life decision of withdrawal and withholding. So firstly, you have to ensure that this process is for those who have lost the decision-making capacity. Where a person is compos mentis and is not incapacitated and can take his or her own decision, then there is no need to go through this process. Because there is every right to refuse any treatment. And you don't have to go to court. So if somebody should lose decision and making capacity and are terminally ill was defined by CMR as when death is coming in the foreseeable future. Across the world, it's about 6 months. In some places, 1 year, up to 1 year. If you think patient is not going to make it, then it's called terminal illness. In a context like that, if the treating team, which should comprise of the patient admitting the physician admitting the patient and 2 other specialists. So the principle is not to take a unilateral decision, but a collegiate, a collective decision. 2 person, and each one should have at least 5 years of experience. The previous judgment was people should have 20-year judgment. That was also simplified to 5 years. And it can be of any specialty. It doesn't have to be certain specified specialties mentioned in the 2018 judgment. So this is the primary medical board. Now, primary medical board, having engaged with the family, is come to the conclusion that withdrawal or withholding is necessary or can be undertaken, refers to a secondary board. Now, the secondary board consists of 3 other physicians independent of the previous 3, and then one of whom should be appointed by the CMO of the district, Chief Medical Officer. Now, this person need not be from outside the hospital. This person can be empaneled by the CMO as a permanent sort of panel. You can, just as you have for brain death, for instance, you have for organ transplantation committees, for instance. So if one empaneled person, 2 others will review this case, and within 48 hours means it doesn't have to be 48. Can be less than that, can be few hours also. So if the secondary board approves, then you carry out the decision, withdrawal, withholding, having intimated the judicial magistrate. You don't wait for any approval of the judicial magistrate. That is not required. It's merely a custodian of this document, this documented decision. So you can intimate the judicial magistrate via email and then carry out this withdrawal, withholding, or life support treatment. If there is any dispute, for example, the secondary board doesn't agree with the primary board and the family says, no, you want a review, then they can go to court, high court. So you see, in the world today, where medicine is quite advanced, that is the world where there's more end-of-life decisions being taken. Treatment limitation decisions are being taken. The hospice movement is increasing, and a lot of people are not going to the hospital anymore, particularly those 80 plus years and those with cancer. Increasingly, they are spending their last days in hospices, where nurses are the primary caregivers. And if they happen to, because 20% of the people in the US die in a hospital or ICU. And in the ICU, at least 70% of people have an end-of-life decision, have a treatment limiting decision. In Europe, European survey showed that 70% that was there in the turn of the millennium has, in the year 2015 to 2017, has increased to 90% of deaths across ICUs in 35 countries. So we need to envision appropriate end-of-life care. We need to produce change. Now there's the modern concept of theory of change. And of course, India needs it. So these are the elements of theory of change. Firstly, you envision, then you take a hard look at the mirror. What is right or wrong with what we are doing? Where there are modifiable, correctable factors which we need to deal with. Brainstorming about where we are. And baby steps taken well. Putting evidence together. Increasingly, there's more and more research output from India in the last 5-6 years or so. So we put evidence together, what is happening on the ground and where we are going and how certain intervention can make a difference. So different things coming together, like this law coming together, different professional groups coming together, there's capacity building, there's advocacy, both from the caregiving professions and outside, from the lay society. And then wherever we are, we have to be champions. Okay, we can't wait for others to do our job. We have to take it into our own hands and then champion the cause, stay true to the cause until we achieve something. So I want to leave you with these thoughts, you have to humanize medicine. If you have to give caring at the best possible level, right? And at the deepest level, then we must change from technocentric care to human-centric care. It's not even patient-centric or family-centric, human-centric. It should be also centered around the caregivers. Caregivers also need attention, support, training, and shift care to the whole person rather than treat as a disease entity or as a number, lab number. Okay. Integrative palliative intensive care is now, we are growing towards that. At all stages, trajectory of illness, you have to integrate palliative care. And then palliative care becomes the primary support towards the end. Use innovations towards patient and family centricity. For example, using an information booklet, right? Or using nurses to interface between doctors and families to deliver appropriate end-of-life care. Nurses look at the patient more closely. They are connecting more closely. Their culture is more caring than physicians. So I think nurses will play a very, very important role here. And advocacy is extremely important. Advocacy must carry on. I thank you for your kind attention.
Thank you, Dr. Mani. That was maybe I would say maybe it is too much for a lot of people. I was also trying to look at the screen and trying to understand what are we supposed to be doing, and we can't be one of webinar and say that we've done it all. So I was thinking about it while you were talking, but let me, if you permit, I'll take some questions from in the chat box. So we have a question from Sandhya Shankar that, sir, though the physician is the person who is responsible to execute DNR orders, living will, etc., do you see nurses playing any role in this entire situation, which you already addressed towards the end of the session? If yes, should hospitals empower nurses to partner in this situation? I think the last part.
I have no doubt that nurses will play a very crucial role. In fact, increasingly more important role than the physician. And we have empowered the nurses in many ways, but not enough, right? I think the partnership must grow. And I think nurses, many nurses, young nurses are eager to participate. And we are not coming out from old molds. You know, there are nurse practitioners now around the world who are a huge interface between the physician and the families. And they have really evolved in cancer care and other things. They are very technically extremely evolved now and trained and confident. This end-of-life care needs even more expertise, to my mind. It needs expertise in communication, expertise in understanding what is end-of-life care, expertise in symptom control, because that's what's the most important. Towards the end, it is not what the big decisions that the physician team is making. It's symptom control. How to look after constipation, how to look after distress, how to give one touch that will make the patient feel better. Without nurses, this campaign is useless. Can't be done. It's all theory.
Thank you very much, sir. And I'm very sure that you will be hearing from Annie or our association soon. Let me go back to the question. Saket Bandal, sir, is euthanasia legally allowed in India?
You see, we must get the definition right. Euthanasia means active euthanasia. Now it is a outdated term, right? Euthanasia is not allowed in India. But the modern term for euthanasia, active euthanasia today, is medical assistance in death. And that is allowed in many countries and about 10 states in the US. Okay. So about maybe 7 or 8 countries in the world and 10 states in the US allow medical assistance in death under certain very strict conditions. And that is a voluntary euthanasia. There's no involuntary euthanasia in the world anywhere. Okay. Voluntary means a patient makes a decision and requests the doctor, and there are certain conditions to be met with. Then certain lethal medicines are given. Nowadays, increasingly, they are being given as barbiturates by mouth. Now, the countries where it's been practiced a lot is Switzerland, for one thing, Germany, Switzerland, and the states and the US. They started with Oregon, the state of Oregon. So they are few and far between. We have not been talking about active euthanasia at all. We are only talking about withdrawal and withholding. That's the modern term. If you use the word passive euthanasia, you confuse it, right? Yes. And it's an outdated term.
So that's well taken. I think the euthanasia word one should not use. That's the premise of it, whether active or passive. It doesn't matter. So here another question from Sandhya. Sir, in India, how do the DNR orders interact with other legal documents like advance directive and living wills?
They interact very well. In the advance will, you can put down a DNR, and you can, if you don't have an advance will also, the family can discuss CPR and DNR. So that is like a withholding decision, and that is, of course, it's constitutional now.
Okay.
Only thing that court has observed is please discuss.
Yes.
Don't take unilateral decisions. Don't take a single person decision. Do it collectively. Do it with the family. So this is the principle, right? And there is a process which you can, if you can put in place the court prescribed process, that makes it doubly safe. Yeah.
So we have a question from Merikuti for DNR. What type of documents to keep in the patient files, or just take the written consent? Is that okay?
You can take a written consent, that will also do, but there are forms. You know, there's a single page form you can download from the ICMR site. Or you can just say DNAR, ICMR, you'll get the. So it's a very simple document. It states the patient, the diagnosis, and the that you have discussed this, and you have signatures by either directly from the patient or 2 family members and 3 doctors.
Okay. Great, sir. And a couple of people are thanking you, and they are requesting if the PPT can be shared.
Please,
so
this PPT is now common property, public property. Yeah.
Okay.
Yeah.
So I will send a mail, and then we will reply to the people who have asked for it, and they all are thanking. And so I have a question, sir, because a lot of thank you is coming. Thank you so much.
There is a question that is DNAR legal? Of course it is. See, DNAR document was prepared by ICMR in 2020 before this simplification came about.
Yes.
So the simplification has only validated it further, right? So you don't have to mention what you're withholding, you know, as in separate laws. Huh? You're withholding CPR, you may withhold intubation, you may withhold vasopressor, you may withhold dialysis. You don't have separately have to mention all that. So you have one constitutional validity of withholding. So that's it. So one thing, we must not now split hairs, right?
Yeah.
Because you want a certain law which is 200% foolproof, you will never get it. So we ourselves, when our time comes, we'll become victims of this thinking. So we will not have a peaceful end ourselves. So please ensure peaceful end to your patients, to family members who may need you, so that collectively the society looks after you when your time comes properly.
Sir, I have a couple of questions. You know, one question is I have gone through one of these experience recently with my uncle. So he had massive, you know, brain hemorrhage, and then they were saying do a surgery with 5%, you know, possibility, you know. So the family called, and then I talked to the doctor. Then I asked, you know, 5% is a figure. What do you think? You know, so finally I had to ask this question: if it is your own uncle, will you, you know?
Okay, yeah.
So he said, no, I will not. So I said, sir, then we should tell the family that, you know, that is how it is. So their withholding was easier. But then withdrawal was, you know, with a lot of resistance from the medical, you know, from the doctors and the nurses. But then slowly they turned around. But the family was feeling very guilty to withdraw. They were okay for withhold. But for withdrawing, they were feeling as though they are going to facilitate or expedite the, you know, death of their loved one. So this is a dilemma that, you know, anybody can. And so what's your experience?
Now in the Western societies, withdrawal is far more common than withholding. They see it as a more definitive closure than withholding, which is a very slow process.
Okay.
Right. So in fact, more than 50% of end-of-life decisions in the world where it is well developed is withdrawal.
Okay.
No, I'm just putting in. See, what you're used to, you do better, right? Initially, you take half an hour to put a central line, then you take 2 minutes in the end when you become an expert. And that process, how it happens, sometimes you don't even know. So this is developing expertise in communication. Okay. So that's also an art and science which you need to actually do to evolve. As communication improves, you are able to settle people's doubts. You are able to give them the emotional support they need to take a withdrawal decision. Right. Initially, people wouldn't want organ donation. Right. It was so difficult for them to just stomach this possibility. They thought the body will be cut and disfigured and all that. But that has given way now to greater, more and more organ donation. Right.
Hmm.
In many countries, it's opt out. Right. I mean, that's the rule.
Yep.
The default. So what I'm saying is we must take the first step. Before running a marathon, you take the first step.
True.
Then it'll get easier and easier. And family support, the ability to touch the families, okay, ability to allay their fears improves unawares as you engage.
Thank you. Thank you so much, sir. One more question from my side is the living will or advance directive. So if you have, like in a hospital setting, you get your patients repeatedly getting admitted. And suppose there are patients whom you know that next 6 months or 1 year, is it okay to educate them that there is a law like this? Because I'm very sure that
We
when
must.
all of
It
us
is
are
in fact,
not aware, they are also not
in
aware.
fact, Supreme Court has also mentioned as part of the obligations to make people aware of such a provision in law, and it's also the same in the rest of the world. You are supposed in if you have a certain diagnosis, then you are supposed to make people aware. See, death literacy and literacy about what our laws are, what it enables. We should tell them. We have been always talking about what it stops.
Yes.
Sorry, we should be telling people what it enables so that they have options. Right? It is only to give you options. It is not to foist another rule on you. It is to say you have a choice in the matter. And that law enables you to have the choice. That is the message you have to give. The other way around. Yes, so far we've been saying there is no law. Law stops you. Law
No.
will not allow it. Only
Yes.
lama is allowed. Where is law says that lama is allowed? Huh? But we are
Yes.
doing this every day. So we have taken a convenient decision and hiding behind the law.
So, sir, what happens? Suppose there is a living will and it's available, but the family says, so he made it when he was like this, and but I am here, I have come from US, I want to do everything for my son. So then how does the healthcare
We have to
professional?
communicate. We have to tell them that we are not here to implement the choice of the son. We are here to honor the choice of the patient.
Yes.
Let us understand, family is also here not to impose their will on us. Family is here to honor the choice of their father, mother, or their dear loved one. So let us set the rules properly, okay, when we communicate. We are not here, I'm not imposing my will, you're not imposing your. We want to understand what would your father have wanted if we were able to communicate. And if he has expressed that very clearly in an advanced way, it helps you. So what I'm saying is, you see, people, when they make these choices, these statements, I want everything done, you have to ask them, what do you mean by everything done? Let us understand you. Rather than say that, no. See, don't get into a confrontation. Get into an understanding mode, because they also need your support. They are also going through a crisis. They're also going through contradictory feelings. So we must separate the wheat from the chaff and get to the point.
True.
What is it that is making you uncomfortable? Share with me. That's a good conversational gambit. What is bothering you? Let's discuss it. You want to talk about things like that. Okay.
Great.
Engage them. Yeah.
True. Thank you, sir. There's one question from one of the doctors. I'm just trying to get the name. I think it's Dr. Shravan. Can a junior, one second, my screen is running away. So I think his question was, can a junior doctor be part of those boards, primary and the secondary board? I
Junior
think
doctor, no, the court has
5
said
years.
5 years or more.
Yeah,
So we have defined it. I mean, what's a junior, what's a senior? It's a
5
5
years.
years experience, which means you have to be of consultant rank, you know. That's
Yes.
reasonable. You don't have to be the senior most. You don't have to have 20, 25 or like me, 30, 40 years experience. You just need to have 5 years experience. Yeah.
So I think that is the end of the questions that I have had here, but I think this is only the beginning of a lot of conversations we are going to have with you, sir, because this is just the tip
I
of.
can see 73 messages. I
They
wish
are
I could
like,
answer all of them.
this is all messages, which are like, share the PPT, somebody came, somebody left, and all those are coming as messages in Zoom. So I am looking at all the thank you. Particular questions I have taken up, sir. And in case anybody has any more questions, so most of them are asking for the PPT. And this has definitely given clarity to people at bedside than just doing without any legal backing. So, sir, I think this is the beginning of many things I think we are going to do
PPT should be
from our
shared.
association with
And
you.
if there are any questions, you can route it through Tankam, and
Yeah,
I
you
will
can
answer
write
them.
to Annie. You can write to annie.reach@gmail.com, or those who have my number directly message. You can reach any one of the, Annie members. So we will try to reach Dr. Mani and get the answer. And I'm very sure you'll be hearing more of this. Sir, I made some mental notes that we cannot just stop with just one dialogue that we have had. The good thing that we got educated about what is the status today. And I think the public needs to be educated. And before that, the healthcare givers need to be educated, nurses as well as, doctors. I'm very sure that even all the doctors are not aware of whatever that you had been explaining, and the documents which are out, the algorithms, the forms which are available. So thank you so much, sir. Thank you so very much for taking time and
Thank
coming
you.
here. And on behalf of all the guests who have joined us here today, and on behalf of Association of Nurse Executives India, thank you very much. And to all the guests who have come here, you are here because you care for patients and care for ourselves and for our own family. So there it is from the expert himself. And we are very honored you consented to spend this time with us. Thank you very much, sir. And all
Thank
of
you
you
all.
there, and we will see you again in another session. Thank you so much.
Thank you all.
Take care. And you want to know more about Annie, please visit our website, www.annie.in. And we will try to, this video is getting recorded, so you can share the video link once we share the link also. Thank you so much, sir, and good night and take care.
Good night.
Stay well.